Good morning, everyone. Thank you. It's an honor to be part of this distinguished panel and have so many distinguished colleagues in the audience today, too. I wish I could say you're getting continuing education credits for this. That'd be nice, but we'll move forward here. What I want to talk about here is HR3717, this bill we introduced last December. I did it last December for a very important reason. I had committed to the parents from Sandy Hook Elementary School that we would have this bill introduced before the anniversary of that tragedy. Our nation has been rocked by several of these tragedies, and although those with mental illness are not of the vast majority likely to be violent, they nonetheless, it is an area of grave concern that so many of these tragedies have been committed by someone with severe untreated mental illness, and that we need to deal with these things. So let's see if I can make this work. No, someone's going to have to sit there and make it work because I have no idea how to do this, okay? This does look fascinating nonetheless. Okay. All right, let me just keep talking here. Let me give you some numbers here, because without this, nothing else is going to make sense to you. There are about 60 million Americans, about 20% of our population or so, that have some degree of mental illness, from the mild, transient, acute problem of anxiety or sadness to severe mental illness. About 9.6 Americans have a serious mental illness, and about 3.6 million are without treatment. Extremely important to understand what happens when someone is without treatment, because if someone is without treatment, they can be more likely to exhibit some violent, aggressive, or assaultive tendencies. But when they're in treatment, there's a 15-fold decrease in the likelihood that they may become involved in violence. It's also important to know this. Someone with mental illness has about 3 to 4 times more likelihood that they will be victims of violence, rape, assault, robbery. And this is whether someone's in prison, on the street, or at home, or independent, whatever that might be. And children who are mentally ill, 3 times more likely to be victims of sexual abuse. Now, those numbers alone are pretty staggering and should move us towards action. But the problem is the actions that have been taken very much are wasteful, are misdirected, and we're not getting the services to people who need it. The federal government, however, already spends a lot of money, about $125 billion towards mental illness. Most of that is for payments for disability. Some is for Medicaid. Very little is for research, and very little is for getting out in terms of early treatment access. Well, what seems to happen, however, is where do these people go? Well, about 20 to 50% of people who are in our prisons are mentally ill. If you look at this next slide, you'll see that as we close the hospitals, particularly in the 1950s and 1960s, well, in the 1950s, we had 550,000 inpatient psychiatric beds for a population in our nation of 150 million. As those beds close down, we now have about 40,000 hospital beds, but where have the patients gone? Sadly, those with serious mental illness, we have filled our prisons. So while states' budgets are bursting at the seams with paying for prisons, growth and expansion, and overpopulation in small prisons, it is no wonder why. It is not that crime is so vast and expanding in our nation, is that we have traded the hospital bed for a prison cell. We have also traded the hospital bed for a mattress in a flop house, in a homeless shelter, or a blanket over some subway grate in our cities. It is inhumane, it is immoral, and it puts us in something of a third world status. And even when we do take some action, such as a typical situation when a seriously mentally ill person is having some acute breakdown, a psychotic break, aggressive, assaultive, threatening, the police are called, they take them to an emergency department, and what happens there? An ill-equipped and ill-staffed emergency room, which is not designed to deal with the mentally ill patient, is brought there. And what do? They tie them by their wrists and their legs to a gurney, oftentimes, too often, leave them in a hallway or in a room that simply is surrounded by a sheet for some visible cover, and if the person gets out of control, they sedate them. What could be more inhumane than putting someone in jail, leaving them on the street, or chemically and physically handcuffing them to a bed and calling that treatment? It is wrong. And it is about time our nation woke up to understand that the plight that these patients face and the turmoil that their families feel about handling this has got to change. So in pursuit of this, over the last year, I held a series of hearings in our Oversight and Investigation Subcommittee, and here's what we learned. We learned that there's inadequate inpatient treatment options, simply not enough beds for those in acute crisis. Quite frankly, there's inadequate outpatient treatment options too. Our system is far, far away from helping people get better, to recover, to get jobs again, to be independent housing, and we know this can happen. The treatment has been out there. There's a number of medications that work, a number of supportive services from peer help that can help. There are community wraparound services. There are treatment folks out there, but unfortunately, there's just not enough of that. In fact, there's a huge shortage of child psychiatrists and psychiatrists overall and psychologists, particularly those who treat serious mental illness. When you're talking about just 7,000 child psychiatrists for 15 million children, and we need 30,000, that's a serious problem. People can't get help. And when there's no help, there is no hope. And when there's no hope, people feel this stigma of going from place to place, emergency room to emergency room, police squad, car to car. And it's no wonder they feel a stigma, because we're part of a society that ignores or maltreats those with mental illness. Another problem we found is that the HIPAA laws, or that Health Insurance Privacy Act, and also the Family Educational Rights and Privacy Act, are subject to a great deal of confusion. They're supposed to be there to protect confidentiality of records, to make sure doctors don't release records inappropriately. I agree. To make sure the Family Educational Rights and Privacy Act is there to make sure people aren't getting school records and other records that don't need to be out there. What they have become is another barrier, because people, for fear of releasing anything, oftentimes do nothing at all. We've had many times people testified before a committee where parents were in a hospital trying to convince someone else, I need to tell you about the history of my son or daughter. And people saying, we can't talk to you unless we have permission. You can't get permission from someone who doesn't even know where they are, that is so severely involved in delusions and psychosis and paranoia at that moment, they don't know who they are. And yet we're telling people, well, until we get their permission, we can't tell you anything. That's wrong. And it's a misinterpretation of the law. It works like this. You know, if you're in an auto accident and you're unconscious, or you have a stroke and you're incoherent, no one says we have to wait until you get better before we make a decision to treat you. We don't do that. Why is it we do that with someone who's in the middle of deep depression, deep bipolar disorder, or deep psychosis? It is wrong. Well, what happens is we need to refine those laws, because otherwise you can't get the history. If you cannot get the history for psychiatric psychological disorder, you cannot diagnose it, you cannot treat it. It is akin to telling an orthopedic surgeon, we want you to diagnose whether or not this person has any fractures in their bones, but we're not going to let you look at any x-rays. Well, we have to stop that. We have to understand that we have to provide some access to information when it's needed, yet still protect confidentiality and follow all the ethical rules of every profession. We also found that there's this imminent danger standard, which has quite frankly existed since the 1700s. And this is the standard that says the person has to be in imminent danger to themselves or someone else. And then you can, without their authority, put them in inpatient care against their will. Again, this standard is to this level that someone has to be basically slitting their wrists, overdosing on drugs, holding a gun or a knife to someone else's throat before we believe they need help. Do we do that with any other medical illness? Do we wait for someone to say, I can't really treat you until your cancer is advanced to stage 4? I can't really treat your chest pains until you're unconscious from a heart attack? I can't deal with your cardiovascular problems until you have a stroke and things have burst? No. But somehow we have this things with psychiatric illnesses that we have to wait till the person has completely deteriorated before we do something. We need to step in and help them, because that is a more optimistic and a better prognosis in assisting them. It's also important that we have evidence-based treatments that really work. There are treatments out there, several of them out there, but what happens is we see a lot of federal dollars and state dollars going towards programs as more along the lines of, quite frankly, many elected officials saying, let's just fund this and put it away. Nobody wants to deal with this problem. People don't want to talk about it. America's big secret. And so we say, let's just fund these programs, and no one asks the question of all these federal and state dollars, does it work? In some cases, quite frankly, they don't work. Some of the money is spent on silly things which would make your blood boil as a taxpayer. Why is it that federal dollars go to pay for a conference where literally the topics are such things as interpretive dancing, stop taking your medication, making a collage, getting in touch with your inner animal? No. You want to go to some weekend workshop for things like that, pay for it out of your own pocket. But when we see millions of dollars going towards those things and telling people we don't have enough people to provide help for you, that is wrong. And we're not going to put up with that anymore. And it goes to this point of weak accountability for federal dollars. And we're going to change that. So what does this bill do? First of all, we empower parents and caregivers with making a very clear definition, refining the definitions of what the HIPAA and FERPA laws are so that providers and family members clearly know. This doesn't mean that someone who has no relationship at all or a family member who's been disjointed from the patient can suddenly come in and get lots of information. No. We want those standards to be clearly defined. So this is a very important tweak. We want them to have access to history when they need it. We would also fix much of the shortage in inpatient beds. Right now, there's a 16-bed rule. Don't know how that ever came about. How do we figure out that we're not going to reimburse you if you have 17 or 18 or 19 beds? You have to have 16. When most states, 48 states, have a critical bed shortage, this has to change. So we boost the number of beds allowed to get Medicaid payment. We also want to make sure there's alternatives to institutionalization. Why should it only be the jail, homelessness, or being in a long-term inpatient facility is enough? Assisted outpatient treatment has been found to be extremely effective in states that do this. Now, a lot of states have this on the books, some like 44 states, but very few states do it. New York is an example of doing it right, where they have found when they, instead of putting people in the 302 procedure is what we call in Pennsylvania, but basically an involuntary commitment. In New York, where things work with the family members or with the district attorney, work with the judge, and come up with an agreement with the patient to stay on your medication, stay in treatment. What they found is that the costs for related medical care and social services and imprisonment fell 46% overall. But in many of those areas, it's much higher, quite frankly, in some areas exceeding 80% or so for people going into jail or being homeless. The other issue is it encourages states to adopt a need for treatment standard. Instead of just waiting until someone is going to kill somebody else or themselves, we look at a need for treatment as a standard. The next item, it reaches patients beyond just the emergency room. CMS recently came up with the ruling that they were going to limit the type of medications available for someone with psychiatric illnesses. We had a rather emotional-packed hearing a few days ago on this, where a representative from CMS was there to tell us they were going to limit the type of drugs that were available. Now, I had to read out loud a statement from the American Psychiatric Association, which clearly said that CMS distorted their analysis of this when they said you can't have certain psychiatric drugs. And in that, one of the comments that was made was about SSRIs. And I said, can you tell me what an SSRI is? And his response was, I wasn't briefed on that. Now, if you don't even know what you're talking about, it's pretty clear that you're going to draw conclusions that have nothing to do with reality. And I'm understating my concern for the decision that was made. And I pointed out that they have another standard within that says that if you're not rehospitalized within 7 days, it's okay to change this. Now, I'm not talking about two equivalent generic drugs, but they were limiting the type of drugs so severely that I thought it was going to greatly impair physicians' ability to prescribe appropriate medication. Now, I added to this, when you're over age 65, for example, and you receive a diagnosis of chronic illness, you're twice as likely to be facing depression. And those who are depressed and chronically ill, you double your healthcare costs for lots of different reasons of exacerbation of physical symptoms, less likelihood to comply with other treatments. So I reminded him that when seniors commit suicide, 20% of them do it the day of their doctor visit. The day of their doctor visit. 40% the week of their doctor visit, and 70% within a month of their last doctor visit. So recognizing that many of these antidepressant drugs, et cetera, take 2 to 6 weeks to become effective, to tie a physician's hands and say, you can't use this drug until you've tried other ones and they failed, puts that patient's life at risk. And I'm happy to say that a few days after that hearing, CMS reversed their decision. But this bill would say, we're not going to leave it up to the whims of whoever is sitting in that chair. We're going to make that part of the law. The same-day billing issue is also quite important, that you can't have two doctor bills on the same day. We know that a family is most likely, and a person is more likely to go to a pediatrician, their family physician, their internist to seek assistance when they're beginning to exhibit some severe mental illness. We know that the average is 112 weeks before a person has their first visit to treat mental illness. But what happens is if a mother's bringing her teenage son, again, 14 to 25 is the age that most severe mental illness symptoms begin to exhibit, bring their teenage son to a doctor, and the doctor says, I'm very concerned about the things your son is saying and doing right now. We need him to see a psychiatrist or psychologist now. Oh, that's right, you're on Medicaid. Can you come back tomorrow? That's inhumane. And we're not going to have that anymore. We're going to say in these cases, there needs to be an allowance for same-day billing. Also, more access to telepsychiatry, a program like the Child Psychiatry Access Project, where physicians can access by calling a number or allow more telepsychiatry since we have a shortage. We know this is a very effective mechanism to do this, to have a mental health professional be able to talk to the patient on a video screen, but it's some billing barriers we have to eliminate. We know that medical research is important, so we authorize the BRAIN Initiative, extremely important program for NIH to involve a lot of research on the brain, that last frontier of the human body. And the RAISE Initiative, the response after initial schizophrenic episode, a very effective program for early intervention for these problems. We also want to integrate mental health in primary care for the reasons I said before about that's where the first appointments tend to take place. But part of this is the bill that Senator Stabenow and Blunt had put into the SGR bill, which was passed yesterday. I had also put in some funding in there, which was approved yesterday in the House bill, and I'm sure the Senate will do that too. Another $60 million to go towards helping with assisted outpatient treatment programs. It's a cause for celebration that those things are out there. More behavioral health IT, that is medical records, are moving into the 21st century where they are electronic medical records, but not for behavioral medicine. And why would that be? We have to have an integrated care model where the brain's function are seen as part of the body and not distant from. Not something you put in jail, not something you call the police for, not something you kick out of your office because you don't want to deal with it. What the brain does is part of the rest of the body, and so behavioral health records also need to be in there so physicians can work as a team. Another part of this bill is through our community health centers is to allow mental health professionals and physicians to volunteer. Now, here's another thing that's so absurd, only the federal government could come up with this. If you work in a community health center, and by the way, these are marvelous places to provide low-cost services to underserved areas, rural and urban. If you work at one of these places, you're covered by the Federal Tort Claims Act, so malpractice insurance is low, and they can provide a lot of integrated care, because the nice thing about this, there'll be physicians and podiatrists and dentists and nurse practitioners and psychologists, social workers, all working together. Great, that's what you want, to provide this team access. But unfortunately, a lot of them are understaffed. Now, if you are employed there, you are covered by this. If you are at a free clinic and you volunteer there, you're covered by the Federal Tort Claims Act. But if it's a community health center and you volunteer, you're not covered. Or if you're at a free clinic and you're paid, you're not covered. So we're thinking, wait a minute. There have been a number of studies that say that people will give of their time to work at these centers. An afternoon a week, a day a month can be very, very valuable in providing for some assisted care. So we're going to take away that barrier and allow people to be the good Samaritans, want to help out, give of their time. And quite frankly, this is probably going to be about $1 billion worth of free care every year in this country at least. Next is in Department of Justice reforms, what I described before about prisons. Unfortunately, a lot of that is guesstimates, and perhaps some of our other panelists can talk about this today. But still, we don't know a lot of what happens in the federal justice system. We want to know what happens with serious mental illness, the treatments. It's a disjointed model. They may have some care or not before they go into jail. They may have a different kind of care in jail, and once they go out, we don't know if they have follow-up care. We want to make sure we're tracking that rather than wait to the next arrest. The teen behavioral health awareness is extremely important to also help teens be educated and understand that serious mental illness, what the symptoms are and how they can seek treatment so they're not afraid of it. And drive evidence-based care through an Assistant Secretary of Mental Health. This is extremely important. Of all this money the federal government spends, there's nobody who looks after what happens at Department of Defense, Department of Veterans Affairs, Department of Justice, Department of Education, Department of Health and Human Services, and maybe even Department of Labor, Transportation, or who knows where else. But a lot of money is spent throughout the federal government on prevention and treatment services for mental illness. And as I said, a lot of it is not evidence-based care. DOD has done some marvelous things. I also serve in the Navy. Currently, I work as a Navy psychologist at Walter Reed Hospital. And I know throughout the military, we've done a number of tremendous initiatives to try and create more care for our active duty and reservists and guardsmen out there serving our nation. But there's this big disjointed thing between that and also the Veterans Affairs system. Someone in VA, I saw a study about 20% of people who contact the VA for post-traumatic stress disorder, 20% get appropriate help. 20%. Waiting lists or people seeing their initial treatments as group therapy or giving medication, say come back in a couple months, is not good treatment. We want an Assistant Secretary of Mental Health specifically designed as a physician psychiatrist or clinical psychologist, say this person's job is to go through every nook and cranny of the federal government, find every dollar and say, is it evidence-based care? Does it make sense? Is there a scientific standard for it? If not, eliminate it. It's duplicative, merge it. If it's great, expand it. Help gather information from states. And I hope Patrick talks about this too. The mental health parity bill that he worked on, incredible thing. It was an honor to work with him on this. But how we can make states are doing these things too, I think is an essential part of what this Assistant Secretary can be doing to move forward. So this is what this bill does. It is very comprehensive. It's not something I can just explain in a thumbnail sketch. But quite frankly, there's three things that I think have happened in the last 50, 60 years in this nation to change mental health. One is the changes that President Kennedy made with regard to how we need to close down our asylums and stop just warehousing people, but move towards real change. But some of those things have withered away, and we need to beef them up. Two is the things that former Congressman Patrick Kennedy did in office to make sure we had mental health parity. But three, these other reforms still need to happen. This is the headline that should be in our newspapers, that the federal government finally stood up and made some reforms and changed these barriers. I don't want to see, none of us want to see any more headlines of another tragedy, of a victimization of a person with mental illness, or of violence committed by a person with mental illness. Let's bring this issue out of the shadows and make some significant changes and help our country move forward. Thank you very much.